Welcome everyone to the second portion of our first QA Forum of 2025. I'm Dr. Michael Novick, the Director of Education and Associate Director of Quality Assurance for vRad. In this second section, we'll be reviewing some more MSK cases that came to our attention through the QA process. Here is our accreditation statement, and here are the learning objectives for this lecture. Our first patient is a 30-year-old woman with right hip pain. We'll begin, as we so often do, with an AP radiograph of the right hip. Here are the coronal T1 weighted images from a subsequent MRI of the right hip. Along with the corresponding coronal fluid-sensitive images. Okay, back to the AP view of the right hip to review our findings. There is a shallow acetabulum, consistent with dysplasia. There is also an osseous bump along the anterior aspect of the femoral head and neck junction, which is consistent with CAM morphology. And there is uncovering of the femoral head resulting from the acetabular dysplasia. Additionally, we can see on this coronal fluid-sensitive image there is subcortical cystic change in the anterior superior acetabulum. With blunting and irregularity of the adjacent anterior superior labrum. The latter two findings from the MRI reflect secondary pathology resulting from underlying femoroacetabular impingement, which of course is our diagnosis in this case. Let's talk briefly about femoroacetabular impingement, or FAI. It typically affects active individuals and therefore young and middle-aged adults. And we reserve the diagnosis of femoroacetabular impingement for symptomatic patients. There are two subtypes with which most of us are familiar. The pincer morphology is more common in middle-aged women and is characterized by overgrowth of the acetabulum, whereas the CAM subtype is most commonly seen in young men and is characterized by abnormal morphology at the femoral head and neck junction. This diagram nicely illustrates the differences between the two morphologies. Recall that we only diagnose femoroacetabular impingement in symptomatic patients because a portion of the population will have the underlying morphologic changes without symptomatology. Both subtypes of femoroacetabular impingement result in damage to the anterior superior labrum. I'm going to very briefly review some of the many signs and tools utilized to diagnose femoroacetabular impingement, but I frankly don't think most radiologists use these. The lateral center edge angle is formed between a vertical line drawn through the center of the femoral head and a line joining that from the lateral aspect of the acetabulum. Generally speaking, if this angle is less than 20 degrees, that is consistent with acetabular dysplasia, and an angle of greater than 40 degrees is consistent with pincer morphology. The ilioischial line is drawn from the lateral border of the obturator foramen to the medial border of the iliac wing. If the acetabular fossa touches this line or projects medial to it, that is generally diagnostic of coxa profunda, which can be seen with acetabular dysplasia or pincer morphology. The crossover sign, or figure of 8 sign, is formed by tracing the anterior and posterior acetabular walls. If the lines cross, forming a figure of 8, that is indicative of acetabular retroversion, which is a form of pincer morphology. If the posterior acetabular wall projects medially to the center of the femoral head, that is indicative of acetabular retroversion or dysplasia. And of course the ever-present alpha angle, which I frankly don't use for the purposes of femoroacetabular impingement because we can't really ever agree on what constitutes cam morphology, but these and other tools and signs are available if you need them. There are numerous articles and resources about femoroacetabular impingement. Here's one that I found particularly useful. Our next patient is a 75-year-old woman with weeks of mid-right femur pain. This is an AP image of the right proximal femur for your review. And another AP image taken 1 week later. And now let's scroll through the subsequent axial T1 weighted images of the right femur. The axial fluid sensitive sequence from the same study. Here are the coronal T1 weighted images. And finally, the coronal fluid sensitive images. Okay, returning to our original AP image to review the findings. There is localized periosteal reaction and cortical thickening along the lateral aspect of the proximal to mid-femoral shaft. This has a characteristic beaked appearance, which we can also appreciate on the MRI. Along with prominent subjacent bone marrow edema, and overlying periosteal fluid. Our diagnosis in this case is another Aunt Minnie, a typical femoral fracture, also known as a bisphosphonate-related proximal femoral fracture. These fractures affect postmenopausal women with a history of long-term bisphosphonate use. They are generally considered atraumatic, although sometimes they come to our attention after minor trauma, and they are frequently bilateral. Major features of atypical femoral fracture include minimal or no trauma. Fractures must be in the transverse plane and involve the lateral cortex, without comminution, and with overlying periosteal or endosteal thickening. 4 of these 5 major features must be present for a diagnosis of atypical femoral fracture. Exclusion criteria include a lack of comminution. You can see there is some redundancy here. These fractures do not involve the femoral neck or intertrochanteric region. There is no underlying bone lesion or bone disease, and they cannot be periprosthetic. For those of you looking to expand your summer reading lists, here are a couple of options. Now let's move on to case number 3, a 67-year-old man status post fall from ladder. Lo and behold, we begin again with plane radiographs. Here is a PA view of the wrist. Followed by a lateral view of the same wrist. If you were unable to identify the abnormality, I don't blame you. These are challenging cases, but I hope you could at least see that there was malalignment. In this case, the lunate has an abnormal triangular appearance on the PA radiograph. The findings, in my opinion, are a bit more conspicuous on the lateral view. There is volar subluxation and tilt of the lunate. Accompanied by dorsal dislocation of the capitate. Unsurprisingly, there is marked associated soft tissue swelling. With elevation of the pronator fat pad. The diagnosis in this case is a midcarpal dislocation, which is on the spectrum of carpal or perilunate instability. These can be extremely challenging cases, so I wanted to briefly review the spectrum of perilunate instability with you now. The Mayfield classification system is the most commonly used and describes 4 stages of perilunate instability. Stage 1 is scapholunate dissociation, which is characterized by widening of the scapholunate interval due to underlying scapholunate ligament disruption. I was taught the David Letterman sign due to the gap between his front teeth. Before my time, it was the Terry Thomas sign. I think maybe now it's the Michael Strahan sign. Whichever celebrity you use to remember this, it is due to widening of the scapholunate interval on the PA radiograph. Stage 2 is known as perilunate dislocation. You can see from this image that the lunate maintains its articulation with the distal radius and the carpus is dislocated posteriorly. Stage 3 is known as midcarpal dislocation. As we saw with our case just a moment ago, the carpus is dislocated posteriorly and the lunate is subluxed volarly. It still maintains an articulation with the distal radius but is subluxed. And finally, stage 4, known as lunate dislocation, which involves complete volar dislocation of the lunate and proximal migration of the carpus. So in this case, the lunate no longer maintains any articulation with the distal radius. I hope that helps clarify perilunate instability a little bit. If you need some more information or are still a little bit unsure about how to make these diagnoses, this is an excellent article to review. Let's move on to our 4th and final patient of the day. This is a 15-year-old boy with knee pain after someone landed on it playing football. We'll mix things up this time and start with a CT scan. Here are axial images from a CT scan of the knee. Here are the coronal images from the same study. These are, of course, bone windows. This one's a little bit of an eye test, so I apologize if I scrolled a little bit too quickly there. I'm sure if left to your own devices to scroll slowly, you would have seen the very subtle fracture line extending to the femoral trochlea. Maybe it's just a little easier to see on this coronal image. Normally we get a nice big lipohemarthrosis to draw our attention to the hairline fracture. In this case we get one, but it's relatively small. I hope you can all appreciate it. So these findings are consistent with a Salter-Harris 3 fracture of the distal femur. Of course, we've all seen numerous diagrams like this one illustrating the different types of Salter-Harris 2 fracture. If you're not familiar with it, do familiarize yourself with this, as we see quite a few fractures in our pediatric population. Thank you so much for joining me. I look forward to seeing you again for parts 3 and 4 of this QA forum.